Chris. Hi, I'm Chris Williamson, and I do want to thank you. I am with Constellation Quality Health. We are a partner of the Health Quality Innovation Network, which serves the states of South Carolina, Virginia, Missouri, and Kentucky. We would like to give a little bit of housekeeping here. This meeting is being recorded, and we will ask that you keep your while we ask that you keep your mic closed when you're not speaking. We certainly want to encourage you. Should you have a question, feel free to unmute and ask. We would prefer to ask those questions, answer those questions as they're asked, because if you've got that question, chances are someone else does as well. I would like to introduce you today to myself. As I said, I'm Chris Williamson. I am a quality specialist for Constellation Quality Health. Joining me today, we have Peggy Peterson, and she is also a quality improvement specialist. Miss Alyssa Pischel, who is our post-acute improvement and state director for the Quinn QIO of South Carolina. Our speaker today is Miss Wilma Rice. Wilma is a master's trained nurse with concentration in education and certification in emergency medicine. She's worked extensively across a variety of progressive positions throughout emergency services and education. Wilma was the recipient of a number of honors and awards, including, but not limited to, induction into Sigma Theta Tau, which is the Nursing Honor Society. She was designated the AHEC Educator of the Year and received the Palmetto Gold Nursing Award. She currently serves as the chair of the Education Committee for the South Carolina Coalition for the Care of the Seriously Ill, and her tireless work advances the work of and passage of the Physician Orders for Scope of Treatment law. I'm going to go ahead and hand this over to our speaker, Ms. Wilma Rice.
Thank you, Christine. I'm happy to be here and hope I can give y'all some information about POST. And we'll just go ahead and get started because we've got a lot to cover. So if we go to the next slide, please. We always have objectives for any presentation. And at the end of today's presentation, I'd like you to be able to define what POST is, be able to differentiate between advanced directives, do not resuscitate orders, and POST forms. Be able to identify who's a candidate for POST. Not everybody is a candidate for POST. And verbalize the need for the meaningful conversation between the patient and the clinician. And I promise you I won't be reading slides to you as we go forward. So we can go to the next slide, please. I always start any of these types of presentations with this slide, and it's the 3 stages of advanced care planning. This came about when we started our POST pilot way back in 2014, I believe it was. I needed something to show to EMS and nurses and doctors where we fit in with POST. So I kind of, advanced care planning is the umbrella, and separated it out into the healthy adults. And this is where the early advanced care planning goes. And we're considering this anybody 18 or older. We really try to reach the younger folks to do some advanced care planning. They have their care goals for everyday health. And this is where we want them to think about what if I go out on the road and have a car accident. And it's hard to get an 18 or 19-year-old to think about that. So it's great if they can do their healthcare power of attorney here and name their agent. Who's going to speak for me if I can't speak for myself? and then look at what healthcare choices are at this time. We're talking about future healthcare treatments. They don't have anything wrong with them right now. So the goal here basically is that healthcare power of attorney. Then we move over into the blue, and this is the adults with chronic illness. Now someone's been diagnosed with congestive heart failure or COPD, and they've started treatment for this. And this is a good time to review their advance directives. Is what I put on paper when I was 19 years old, does that still fit my needs for right now? And update it as they need to. And then we go into the tan, which is the adult with serious or life-limiting illness. And now my disease that I was diagnosed with at 45 is really gotten hold of me, and I'm going to need to have decisions made for right now, not future decisions. This is what I want to happen at the end of my life. This is the way I like to put it, this is how I want to live the end of my life. And we have the treatment goals, and then this is where we're going to bring in the palliative care so that they can help manage shortness of breath, pain, any kind of symptoms I'm having. And this is where the post comes in. This is where we get those transportable medical orders that can go with me anywhere. So that's an overview of where post comes in with all of this. And you can see advanced care planning is not a one and done thing. It's really, and if we start it at 18, then by the time we get to post, it's a normal conversation. It's not something new that somebody's hitting me with. Okay, next slide. Love to start with patient stories. And the story I have here is the patient in the hospital did not have any advanced directives or any documentation of end of life care that anybody could find. And he was on a 17-day hospital stay, intubated on a ventilator, really, can't communicate a whole lot there. And this was the third hospital admission within that year. So are you seeing some red flags here? And sadly, the doctor had it as an order in the chart for advanced care planning to be done. Now, I don't think he should have put it all on somebody else. He should be part of it, but even wrote what he was looking for: assessing spiritual needs, discussing any advanced directives, a DNR, comfort measures, wanted to look at all of this for the patient. And nowhere on this man's chart was there any documentation that those orders were done. Nothing. And for whatever reason, there's just a ton of missed opportunities. Number one, a big flag here is the 3 hospital admissions. And the patient is 17 days in the hospital, and we don't know what he wants, and he's already intubated on a ventilator. So there were a lot of missed opportunities here. It sadly is what happens to a lot of people who are seriously and or chronically ill in South Carolina, and I'm sure North Carolina too. And it highlights how people get into this vicious cycle of hospitalizations. It's workflow processes. The hospital didn't have any workflow for advanced care planning. Who does it? When should it be done? How do we do it? And then the poor documentation. It's hard to find documentation. I know Epic is a little bit better. My old system had Cerner and then went to Epic. And in Cerner, you just really couldn't find it, or we couldn't. And then in Epic, it got a lot better. But it's still difficult to tell the patient's story with the electronic documentation. So we need to have that face-to-face to see what the patient is feeling and all. And just a normal progression of care here that didn't happen as it should. So kind of a sad story. Next slide. So some general information about post we're going to go over. It's not going to be about how to fill out the form, but you'll have my contact information at the end, and you can certainly send me an email. But I love this saying by Wells Shoemaker. And if our health systems fulfill their goals and deliver compassionate, consistent care, we will have a society that makes sure that individuals' personal wishes are honored and how they would like to approach their waning days. So this is what we should be doing with folks. All right, next slide. So what is a post? Physician order for scope of treatment. That is what we have in South Carolina. North Carolina has most. You will hear Louisiana has law post. Iowa has iPost. So states can choose what they want to call it. POLST was the initial acronym, and back then it was an acronym, Physician Order for Scope of life-saving treatment. And they've gone away now from an acronym. It's just POLST. And there's a national organization, National POLST, that kind of helps states out with this. So POST is a standardized medical order. It's not an advanced directive. It's a medical order. And by law, it's recognized across healthcare continuum in South Carolina. Wherever that patient goes, that post is portable with them. It belongs to the patient. So at a facility would need to copy the post and give it back to the patient. The facility does not keep the post. And it should go with the patient, and maybe a copy go from one facility to another. Say a nursing home is sending a patient to dialysis outside of the facility. The post should go with them so that those at dialysis knows what the patient's wishes are. The post allows folks to choose which medical treatments they want or don't want. And that's one of the beauties of it. If somebody wants to have CPR, they can say, I want CPR. And hopefully it gets carried through. Some people, they're used to getting better and going home. And, take a COPD patient, they have an exacerbation, they go to the hospital, get intubated, get better, go home. Exacerbation, hospital, intubated, better, go home. So they're likely to say, I want to CPR. And at some point in time, somebody needs to have the conversation with them and ask them, at what point would it be not appreciated by you to be intubated? Mm-hmm. It is completely voluntary. And I have put this in red because there have been cases where nursing homes have actually made it mandatory for a patient to have a post to be admitted. And in South Carolina, that is illegal. In all states, it's illegal. And all 50 states has some type of post, either in the process or instituted. We cannot mandate a patient to do a post. Right? And I think that's one of the biggest things to take out from this. It helps provide directions for healthcare providers for the patient who, during their illness and at the end of their life, it helps EMS immensely. Their DNR, the EMS DNR, says don't do DNR if they are dead. Their problem comes in, what if the patient has an EMS DNR, but they're still alive? How far do I go? The post answers that question. So the post does a whole lot of things. Next slide. Kind of restated, it's a medical order. It transfers across all care transitions, and it really does help guide EMS. And I have a picture of it here. And again, I'm not going to go through each piece. You can see what it is. You can go on mylifemychoices.org and pull this up. But I really want to let you in on section B as one of the most important things, because this is what the patient wants if they still have a pulse and are breathing. So they may have said, if you find me dead, I don't want to be resuscitated, but if you find me alive, I do want to be treated. So A and B have to match. If they want full treatment in B, they have to want attempt resuscitation. So that's all I'm really going to say about the chart itself or the form itself. But it's not a one and done thing with post either. Uh, the post form needs to be reviewed at certain times, and this would be when the patient transfers from one care setting to another. So, for example, that patient who goes out of your facility for dialysis, the post or copy of the post goes with them. And when they get to the dialysis clinic, they should review it and say, I see this is what you want. Is that still in effect? Yes. Okay, that's fine. So now we know. And then when they go back to the nursing home, it should be reviewed again. And it doesn't have to be a big, huge thing. Just, is this still what you want? So anytime they go from one setting to another, if the patient's health has a serious change, you would want to review the post with them. If that change is so serious that they can no longer speak for themselves, this is where the healthcare power of attorney comes in, because they can make changes if the patient can't speak for themselves. If the patient still has capacity and they decide they want treatment changes, yeah, I know I had a post saying this, but I'd rather have it say this now. So we would have to revoke the old one and do a new one. And when you have a patient care conference, if they have a post, that's an excellent time to review what the post says, what it means for the patient's care, and kind of double check with the patient. Are these still your goals of care for the end of life? And just keep in mind that patient that has capacity or their legal representative, their healthcare power of attorney in South Carolina, can request a change in treatment or revoke a post. The one thing that kind of has us, we're not sure how we feel about it. Well, I'm pretty sure how I feel about it is that if I can no longer speak for myself, my healthcare power of attorney, who my husband, could actually revoke my post. And that's somebody I would have to look in the eye and say, are you sure you would want to go against what so and so wanted? But that can happen. Okay, next slide. I've got a comparison chart here because questions have come up. Why do we have a post? We already have an EMS DNR. We have advanced directives. I named so-and-so as my healthcare power of attorney. Why do I need this? They can make the decisions. And that's all true. But I wanted you to see the differences here. There's a lot of similarities, but there are some major differences. So I have advanced directives, the EMS DNR, and the post listed. Advanced directives, it's a legal document that they normally talk to a lawyer about. And nothing against lawyers, but most of them don't have a whole lot of medical history. So they make a legal document, and this is the healthcare power of attorney, and that's wonderful that they're doing this. But currently, our healthcare power of attorney has some choices for treatment on it too. We make a big deal of post being a medical order. Well, the EMS DNR is also a medical order, right? So we're going to see the big difference at the bottom of this. Who is it for? Advanced directives, we want everybody, like I said, 18 and older to have advanced directives. The EMS, the way it is written on the EMS DNR is it's for a patient with a terminal illness. That's the only patient it is. A post is somebody that's seriously ill or they're expected to die within the next 12 months. And that's the big criteria we'll talk about shortly. So there's some differences in who this applies to for each one of those forms. The advanced directive is their healthcare agent, possible future treatment. The only choice on the DNR is do not resuscitate. That's the only thing it covers. It doesn't tell them what to do if the patient's still breathing. then that's the beauty of the post. They can choose to be resuscitated if they want. That's their end of life goal. I want to live as long as I can. Um, or they can choose do not resuscitate, and it applies to other treatments too. I don't want you to put a breathing tube down. You can do everything else to me, but don't put that breathing tube down. Or I just want comfort care. And that's hard for people to put sometimes because they're scared they're going to be forgotten, but that's not what it means. So post opens up a lot of other care options. The advanced directive is it's the individual. No healthcare provider signature is required. The individual signs it. It can, it's an optional for a notary public. For the EMS DNR, it can be physician, APRN, PE, or PA, and the patient sign. And then post is same people can sign the physician, APRN, PA, and the patient. The big thing here is after a shared decision-making conversation. Pretty much with the EMS DNR, we think you should be a DNR. So, and I know they have a little bit of a conversation and tell them this is what's wrong, you're dying, and do you want to be a DNR? Here's the big one. Advanced directive does not guide EMS. The DNR for EMS is only for EMS personnel. It's a medical order, is honored outside only by EMS. And by what I mean by outside is outside of the hospital, the nursing home, out in the field, so to speak. It doesn't provide guidance to in-facility people. A lot of facilities kind of here, oh, they have an EMS DNR, so we're going to make them a DNR here. And they just follow that EMS DNR and let it come into the building out. It does not guide in-house care at all. The post, this is where the big difference is. It is honored across all healthcare settings. So if George is out on the back nine playing golf and he has his post in his back pocket and they are taught to have it with them, and you can have a post and be moving around. He's got his post in his back pocket and he goes down on the ninth hole. And that is an actionable medical order. When EMS gets there, they can honor that. They still are going to call their medical personnel, medical director, but they can honor that and not do CPR on George. If he's got an advanced directive stuck in his back pocket, they're going to do CPR. So that's the huge difference there is it can guide EMS anywhere. And once the EMS brings them into the facility at the hospital, it guides them there. And now they say, well, what if this doctor is not on staff? Well, you look at it, ask the patient or the representative, is this what they still want? Yes, and they write orders to cover it. And nursing homes do the same thing. However you put it in your policy to use. So I think this is a really good comparison of all about post. So I'm going to just stop talking. I tend to talk pretty fast and see, do y'all have any questions about any of this? Is there anything I can answer so far about post?
Hi, Wilma. This is Chris. As I understand it, the advance directive tells someone, our family and that sort of thing, it reinforces to them what our preference is, but they can override that with their personal decisions.
Yeah.
But with the DNR or the post, is there the opportunity to say, I am okay with chemical resuscitation, but I don't want anybody doing manual resuscitation? I'm thinking the DNR doesn't have that, but the post does.
You don't differentiate.
Mm-hmm.
They can say under section B, they can put other, there's a place for other.
Mm-hmm.
But if you choose to be resuscitated, it's hard to hamstring EMS or even in-house personnel. That is not a real option. You either are going to be resuscitated or not for the post. Now, again, in section B, you can say full treatment is everything. I'm going to throw everything we have to try and keep you alive or get you back. The second, limited treatment, the way we limit it there is we're not going to do CPR, or we can do CPR if you're found there, but we're not going to intubate. You can do what you want to me, but don't put that tube down my throat. And then the one that says you don't want to be resuscitated, and I do not want anything but comfort care.
Okay. Thank you.
Yeah. And like I said, A and B have to match. So if I choose to be resuscitated, I have to choose full treatment. Do not resuscitate. It can be limited or comfort care.
Okay.
All right. Anything else?
Hey, Wilma, this is Peggy. And I was wondering, is this recognized in all states? So if you're in South Carolina and you have this and travel?
Okay, great question. Most states, and I can't speak for every state, but one of the things the National Pulse does is try to get things to match as much as possible. They even have a pulsed form that some states are adopting. But South Carolina, the law says if an outside state's form is similar to our state, then it can be recognized. And a lot of states have that same type reciprocity. If our form is similar to theirs, it would be recognized. Now, the safest thing, and we actually get questions. I'm bringing my mom to live with me for 6 months this year, and she has a New York post. Should I get one in South Carolina? The New York post would be, without me looking at it right now, we'll just say it would be honored here. But the safest thing, since it's going to be an extended time, would be to go ahead and get a South Carolina post. But most states have the reciprocity.
Great, thank you.
Okay. Anything else? All right, then we'll go with the next slide. We can move to the next slide. Okay, there we go. All right, planning for posts. This is a process, not a one and done type thing. And just kind of repeating here, making sure the treatments are consistent with the wishes, goals, and beliefs, if unable to speak for itself. And that comes from the CDC definition. For me, it's letting the loved ones know what matters most to you. And the little circle I have over here, I think this kind of puts things in perspective to keep the patient in the center of everything. Our patient-centered care is so important at the end of life. So that's what the post covers. And remembering that the process is not just for the elderly. Age has nothing to do with it, but it's for those with a serious diagnosis or a frail person. And South Carolina is based on it wouldn't be a surprise if they should die in the next 12 months. And the overall goal here is you want to have the people to be able to access your wishes at the right time when they're needed. You want people to be able to get to, or you want you to be able to get to the services you need. So maybe somebody goes on hospice. And when we put my dad on hospice, I've been a nurse for 43 years at the time, and I had no idea what hospice could do to help. You want to be able to be cared for and to die where you would like to be. Marissette, if she's on, I can't see everybody that's on. She knows that my husband and I moved in with my dad basically for the last 2 years of his life. And this farm that he lived on, 12, 14 acres, was his life, and he loved being in his barn, huge barn out there. And we moved in, basically, he had gone down to 128 pounds and just not cooking and eating and all. We moved in to take care of the little things like cooking so that he could spend his time in his barn. And he was doing things. I mean, he died when he was 93. So at 92, he was climbing 16-foot ladders. At 92 and a half, he was climbing 16-foot ladders. And I'm saying, Daddy, please don't do that. Don't do this. Don't do that. And I finally had to come to the conclusion that if he fell off that ladder and died, he would die happy. But we had to have these conversations. And if I didn't have this training with post and advanced care planning and how to have the conversation, I wouldn't have been able to do what needed to be done, which was pull my chair in front of him and ask him what he wanted. And he wanted to be on this property when he died. And that's what we were able to give him by just knowing what he wanted. And he didn't really want to be involved in the decisions. He was of that age group that you don't talk about death because you might cause one. And I had to drag it out of him. And so, but some other people may want to be involved in every decision for the end of their life. And then the support for their emotional, physical, social, spiritual needs. We know that once somebody learns that they're dying or they're so sick, that a lot of times they are left lonely. So planning for post can include what I want to happen spiritually. I want to be able to see my minister once a week. I want to be able to hear the sermon. I love having get-togethers with my friends. So it's, again, not one and done. It's a circle. It happens all the time. And for medical personnel, the post means you're able to make sure that your patient's treatments match, and because you communicated with them. And it lets your loved ones know what you want. It really does, and it helps. It helps. Next slide. So going into the planning a little bit more, and I'm not going to belabor the point here, is it's two parts. All right, there's the conversation, and that conversation is with the loved ones and their family, and at least their legal representative if nobody else can be there. And then with the physician and other healthcare clinicians. The nurse is taking care of them, the techs is taking care of them, the chaplains, all of these people are included. The social workers are so important. And then once that in-depth conversation, and there's courses on how to have this conversation, then we complete the document. And the document is gravy to the conversation. That document has no context to who that patient is without the conversation. And again, I'll say if we start with the 18-year-old with a healthcare power of attorney, by the time they get here, it's a normal conversation. And it's not a surprise to the patient that they're going to have that conversation. Next slide. So with the quality conversations, the part about this is it makes post more than just a checkbox form. Yes, we do have little boxes you have to check, but you've got the conversation backing you up. And these conversations are looking at what matters most to the patient and what fears do you have. So a lot of times when you're talking to people, you ask about things going on, and you'll hear something like, I don't want to die like mama did. And you hear that as a fear. And so you want to follow up on that. And what about mama's death bothers you? What happened with mama's death that bothered you? Well, I saw them do this, and I don't want that. Then when you go to do the document, if they're having trouble choosing, you bring this back up. Well, when we spoke earlier, you said that when they did this to Mama, that you didn't want that. Is that how you want to record your wishes? Something like that. Unfortunately, most healthcare professionals haven't been trained to have these conversations. Doctors weren't trained. I can say that medical school at MUSC, we actually started helping them and introduce. They had a course where they got some about advanced care planning, but we were requested to go in. And when I say we, I'm talking about My Life, My Choice, and then the CSI organizations. I represented them to go in and help beef up their conversations and stuff like that. They had homework around it so that when they had to actually do advanced care planning with a senior in their senior year, they weren't so scared. And so that it really helps to have these conversations. And by not having the conversations, the result is really concordant care for the patient, and actually can cause moral distress, moral injury to the clinician, because they know in their heart that they didn't give the patient what they needed. And like I said, it is inclusive of the family and or the healthcare agent. And I will say that My Life, My Choices uses two models to train clinicians: serious illness conversation program out of Ariadne Labs, and Respecting Choices facilitator programs for like social workers. And so we try to fit the course to the needs for this. The serious illness conversation is the easier for the clinicians because it's 3 hours long. All right, next slide. Let's talk a minute about who is post best for. What's the criteria for a patient being offered a post? And it's individuals diagnosed with a serious illness. And our law even defines serious illness as a condition which, based upon, in bold letters, best medical judgment, is likely to result in death within a period of not to exceed 12 months. Well, that's what our law says. Nationally, they're going more to a 12 to 24 month, but our law says 12 months. And some folks are worried that, well, what if we do a post and they don't die within 12 months? I look like I don't know what I'm talking about. Nobody gets dinged or approached if the patient's still alive after 12 months. You don't get in trouble if the patient lives past the 12 months thing. But the key words here is best medical judgment based on what's going on with the patient, the diagnosis, and how it's affecting them. I think it might be within 12 months. So they meet criteria. The other individuals, and we were very intentional with this in the law. We had the Alzheimer's group at the table. And it's also best medical diagnosis that they may be expected to lose capacity within the next 12 months. They won't be able to make their decisions to let somebody know what they want within 12 months. So maybe I'm diagnosed with some sort of dementia, and right now I don't have many symptoms of it, so I have capacity to make decisions. I can go ahead and do my post. All right. And again, best medical diagnosis. So that gives a lot of wiggle room there. And again, nobody's going to get in trouble if after 12 months I can still make decisions. Next slide. I'm going back to patient-centered care. Just as a reminder, there's really two aspects here. It's the patient's perspective and the medical aspect. And when we do these conversations, you need to realize one big thing: there's two experts, not just the clinician. They're not the only expert in the room. There's two experts in the room. The patient is the expert regarding what matters most to him or her. So that patient is an expert, in their life and how they've lived it and how they want to live it at the end. And the clinician is the expert about the medical piece, the disease process. So I so many times when this conversation is going on, because they're untrained, it's the thought process, well, I'm the expert, you're the patient, you should listen to me. That works the other way too. The patient is the expert on themselves, and we should listen to them. Next slide. Post has some great impact on healthcare professionals. There's several positive impacts. Number one, you increase your skill in having these conversations. Practice, in this case, doesn't make perfect, but it makes it better. You have less stress in having the conversations. You're able to help your patient better. You have increased engagement with the patient and the family, and that helps you take care of them. And there's, I think the big thing is we feel good about that goal concordant care. We were able to treat the patient like they wanted to be treated. And all of that leads up to a decrease in moral distress. You've got increased job satisfaction. And how much do you see nowadays about burnout, compassion fatigue, all of those types of things? The job satisfaction by a job well done for the patient helps you feel better about your job. And you're more likely to complete your advanced care planning paperwork for yourself and your significant other. And that's a huge thing because statistically, only about 1/3 of healthcare providers have done their own advanced care planning. Okay. I don't think any of us are in the need for post right now, but just getting your healthcare power of attorney name. And, I want you to, I'm not going to say everybody raise their hand if you've done your healthcare power of attorney or whatever, but just do a self check. Do I have this in place? Does my loved one know what I want? I have to tell you, my son is in his 30s. And way back when he was 18, he had his will done when he went to college. And when he went to go to Idaho to get his master's, he had a will done and he had the healthcare power of attorney, which was me. And I was glad. They were going to have to call me if something happened to my child, 2,742 miles from my doorstep at the time. He's my baby, y'all. And go forward, when he comes home and gets married, my son comes to me and has a conversation and says, Mom, I think I still want you to be my healthcare power of attorney because my wife has panic. She panics easily and she gets anxious very easily. And I don't think she could make a decision in the heat of the moment. And I said, well, I appreciate that. And I would love to be your healthcare power of attorney. But I would still run anything big by your wife because it's going to affect her too. But for a 20 something to come to their parent to ask and talk about it. So that tells me we were doing a good job of having these conversations. And he recently called me and we talked about it again because he's updated his will and he's made something joint between me and his wife because just for me to help her through it. So you're more likely to do your own healthcare work. Okay, next slide. Right now, the state of the post, I have to be honest, we need to get it out there more. So we're going to ramp up our education about post because there's a general lack of knowledge. The governor signed the post law in May of 2019, and y'all may or may not have known what happened at the end of 2019 and 2020, this little thing called COVID. And it just derailed all of the education, especially with EMS. So we're ramping up our training about post. There's still fear about having the conversation about dying. Advanced care planning documents, people get them confused. And I know we have run into an issue with nursing homes, long-term care facilities, about a two-physician signature requirement. The post does not require two signatures. And by law, it states nursing homes that post is applicable in nursing homes. It names a whole list of things, including nursing homes. So we're trying to find out more about this. I need somebody to show me where it says two physician requirement. So we're trying to find out more about it, but it is a barrier right now. So there are barriers and we're trying to rectify them. And that's why I was so appreciative of being here today. Next slide. We have My Life, My Choices. This is a screenshot of their website. It's changing right now because we're updating everything, but it gives the people who access it, it has news articles, educational materials. There's online training, interactional training for how to complete a post. And it takes a very short amount of time to do it. So if you go to the website, you can actually take a course on how to complete a post. And you can actually download the form itself from there. So a lot of information about post on there. Next slide. I know I'm getting close to time here. Kind of our tagline with CSI and My Life, My Choices is we want you to think about it, then talk about it, then write it down. So you think about it in your head, talk about it with your loved ones, complete the form. If it's advanced care planning, complete the healthcare power of attorney. If you're at the end of your life, do the post and then share it. All right. So many people will do a healthcare power of attorney and never tell the person they're naming that, hey, you're my healthcare power of attorney. This is what I want. I told my son when he said he's changed, he's updated his will, and I'm still going to be making medical decisions. Okay, we need to talk. We need to update it. So you have to share it. Next slide. I'm going to bring it to a conclusion here, and post is more than a form. It really does help start the quality conversations with patients, with their families, with their physicians. So many patients wait for the doctor to bring it up. My doctor almost swallowed his tongue when I said, hey, do you want me to give you my advanced care planning documents? He was like, what? It doesn't replace advanced directives, it complements it. Okay. And it really is meant to help those seriously ill or frail individuals. And it goes way beyond the scope of the DNRs, especially. And just remember, it's not just for emergencies. Oh no, George dropped on the back nine, on the ninth hole in the back nine. It's about that guidance for everybody as they move from one healthcare setting to another. So if they're going home from the hospital to home, they can put the post over the head of their bed so EMS can access it and see it. If they're going to a nursing home, the best thing you can do is go ahead and make a copy, make two copies, put one in the front of the chart, however y'all do it, and then have one ready to hand to EMS so that they can have one immediately. And then it helps providers make plans to help align treatments that may not be covered. Because we're having the conversation, let's go ahead and ask about this treatment. So it really does help a person live the end of their life the way they want to. Next question, next slide. So here's my big question mark. And I see in the chat about, Alyssa put, does anyone have any challenges or barriers with completing the post tool? I would really love to know of any. And you can go ahead and go to the next slide, and that has my information. Wilma.rice@gmail.com. Not hard to remember. And just please identify in the subject line that you're making a post inquiry so that I know to jump on that. All right. So questions, thoughts that I can help you with.
Please feel free to unmute or put your question in chat for
Yeah.
Wilma.
Yeah. I'm happy to entertain anything. I will say on the mylifemychoices.org website, we've had a number of people do the interactional training on post, and it's been helpful to them. It's animated and just it's in little snippets. So it really has helped people with the post. So feel free to access that.
I see a number of people have unmuted. I don't know if that's because you wanted to ask something. If it is, this is your time.
I realize this is Jim from Rock Hill. Here in our setting, we're a retirement community setting. We have independent living, assisted living, skilled nursing, sort of the gamut.
Right.
And I realize this is, the audience is skilled nursing only, but where we use the post form in our independent living, because our average age in independent living is 87.
Oh, wow.
And we have a lot of people over the age of 90. Once a year, we encourage our independent living residents, which is by far our largest group of residents here, is independent living, to update, just not their medications, but also to keep an envelope on their refrigerator door that would have their advanced directives and emergency contact information, etc. And that's very helpful when EMS comes, because when you have a demographic of independent living at our age group, people do fall. And very helpful when EMS comes to pull that envelope and see if somebody has already completed that post form. And you'd be surprised at the number of people over the age of 90, even though they do not have an expected death within the next 12 months or 18 months, they have already thought through clearly what they want and what they do not want. And it simplifies things with EMS when they do come. So, I think these post forms are just great ways to help people sort through their end of life thinking prior to it being an emergency.
Right. It, like I said, it's not just for emergencies. It's as long as you're not requiring. I think anybody that's 90 years old, you could almost expect their death at any time. But when I do the full-blown post-education with how to fill it out and all, I use my dad a lot. When he was 89, he wasn't a candidate for post, because he was active out there and doing things and all. At 92, he was a candidate. But we don't want to make it just about age. That's an important point. But with and your setup, I'm assuming that you're their physician or for the place. But if a conversation is held between you and the independent living. And like I said, at 90, you could expect it to happen at any time. And I've had a number of people that have thought it through and say, I want to post. And you as the physician say this could happen. So we do a post. Best medical judgment. They're not trying to say that have to have this decision or this disease, that this terminal illness, just as long as it's not mandated that you do a post. And I think a lot of active elderly do think about this. All right. And in the settings where you have the independent, the assisted, and the skilled, I think it's more, and I don't mean this in an ugly way, in their face. They see the different levels very clearly. And so I'm glad you're using it. And I just, the refrigerator, we always taught EMS to look on the refrigerator too. And initially post was bright pink, but we can't supply everybody that's printed off with bright pink paper. So it's printed on white paper now. And we tell them if the person is not up and moving around active, we tell them they can put it on the side of the refrigerator or over the head of the bed. Just don't put it in the freezer, because I've had folks say that their lawyer told them to put their healthcare power of attorney in the freezer because if their place caught on fire, that would still be there. We don't want to put them in the freezer. But we did have one case where EMS forgot to get the post off of the side of the freezer. And because the family had been told that EMS will get your post when they leave or when they get there, the family didn't get the post either. So the patient went to the EMS, went to the hospital, and ended up being intubated, put on a ventilator, and that's the one thing he didn't want. So the family did go back when they were asked, do y'all have anything in writing about what he wants? They went back home and got the post, brought it, the patient was extubated, and the rest of his wishes were carried through. So we learned there that you have to be careful what you're teaching the family, because they had been told EMS will get it. They left it there, even though EMS forgot it. So some people are very literal.
We are at the end of our time, and we want to be cognizant of how we use your time. Should you have any further questions, if you will send them to us, we will be more than happy to refer them over to Wilma. We thank you for your time today and look forward to seeing you in the future.
Thank you very much.
Thank you.